So we're moving on now to hepatitis, and to start us off is Dr. Reingold. In a moment.
Good morning, everyone. I'd like to offer my personal congratulations to Dr. Plotkin. And we will certainly miss him at future meetings, but I won't be here either, so I guess you'll miss me too. We're going to have several presentations this morning about hepatitis vaccines. Let's see if I can figure this out. So just to remind you that the Hepatitis Working Group terms of reference currently include updating recommendations for hepatitis A vaccine use, an evaluation of a new hepatitis B vaccine in terms of its what we know about its immunogenicity and efficacy and safety. I will remind you, if you were at a prior meeting, that the working group is interested in trying to improve prevention of hepatitis A in adults and have wider use of the vaccine. And I will also remind you that the ACIP, in its wisdom, asked the working group to do a little more work on that subject in order to convince them that how one might do that. So since the June meeting, the work group has been looking at a variety of issues around hepatitis A and hepatitis A vaccination. And the work group here has been very, very involved in responding to a number of very substantial hepatitis A outbreaks, which we will hear about, as well as hearing the data that you'll be seeing this morning about a new hepatitis B vaccine. So this morning we're going to have three presentations in the hepatitis section. One from Dynavax about this new hepatitis B vaccine, and then one from Noel Nelson about the work group considerations about the new vaccine, and then a second presentation from Dr. Nelson about hepatitis A outbreaks, so that we're up to date on that. So there won't be any votes around hepatitis vaccines this morning. We will ultimately present a full updated hepatitis A vaccine statement for a vote, and certainly there'll be continued discussions about hepatitis B vaccination, and at the time any new vaccines are licensed, they'll certainly be presented for a vote. So as is the case, we have a number of people who are working really hard on this, including other ACIP members listed here, some very, very active liaison representatives and consultants, but of course the real credit in all of this goes to Dr. Nelson here at CDC. She and her colleagues in the Division of Viral Hepatitis and others have been instrumental in getting us to this point. So at this point, I will ask Rob to come up from Dynavax. Rob is another former EIS officer who's quite at home here at CDC. So Rob.
Good morning. I'm Rob Jansen, Chief Medical Officer at Dynavax Technologies, located in Berkeley, California. Art, I said it just for you. No, things happen in California too. I'm really happy to be here today to present our data on HEPLISAV-B. In my presentation today, you'll hear that in adults, HEPLISAV-B provides significantly higher and earlier protection against hepatitis B compared to an existing hepatitis B vaccine using fewer doses and with an acceptable safety profile. Now, like the currently approved hepatitis B vaccines, HEPLISAV contains a yeast-derived recombinant hepatitis B surface antigen. This surface antigen is produced in Hansenula polymorpha. Over 1 billion doses of this antigen have been administered worldwide. So the major difference is in the adjuvant. HEPLISAV uses a toll-like receptor 9 agonist that we call 1018, whereas the currently licensed vaccines use aluminum salts. HEPLISAV is a sterile liquid dosage form in 0.5 ml dose vials. It contains 20 micrograms of surface antigen and 3 milligrams of 1018. It's administered in 2 doses over 1 month by IM injection, compared with the current 3-dose 6-month series. The Adjuvant 1018 is a small synthetic single-stranded oligonucleotide that has specific immunostimulatory CpG sequence motifs that mimic the natural innate immune response to viral and bacterial DNA. This innate response activates antigen-presenting dendritic cells that lead to enhanced B and T cell responses to co-administered antigens. The actions of 1018 are mediated by its interaction with the well-defined receptor, TLR9, that's primarily expressed by plasmacytoid dendritic cells. The proposed indication for HEPLISAV is for active immunization against infection caused by all subtypes of hepatitis B virus in adults 18 years of age and older. The PDUFA action date is in 2 weeks. I'll now present the data for immunogenicity for HEPLISAV. Our immunogenicity data are based on 3 pivotal phase 3 trials, HBV10, HBV16, and HBV23. In each of these trials, different randomization rates were used, ranging from 2-to-1 to 4-to-1. The 3 trials share common design features. All 3 were observer-blinded, randomized, active-controlled, and multi-center. Trial participants could not have evidence of current or previous hepatitis B infection. They could not have received a previous hepatitis B vaccine. Persons with HIV or immunosuppression or history of autoimmune disease were not eligible for the trial. The demonstration of seroprotection, and the seroprotection rate is percent with antibody to surface antigen greater than or equal to 10 milli-international units per ml, which is the surrogate of protection for hepatitis B. And this was all based on head-to-head comparisons with Engerix-B. Now, lastly, the concentrations of antibody to surface antigen were measured using an approved commercial assay. All trials were designed to demonstrate the primary efficacy, non-inferiority at the primary endpoint of the SPR induced by HEPLISAV to that compared with Engerix. Non-inferiority was met if the lower bound of the 95% confidence interval of the difference in SPRs was greater than minus 10%. A statistically significantly higher SPR was achieved if the lower bound of the confidence interval of the difference in SPRs was greater than 0. The per-protocol population was used in these analyses. Now, this slide is illustrative of the study design of our pivotal trials. This is HBV16, in which we evaluated immunogenicity and safety among healthy adults 40 to 70 years of age in the United States and Canada. 2,452 subjects were randomized 4-to-1 to receive HEPLISAV or Engerix, and then they were followed for 52 weeks after the first injection. Demographics within the 3 studies were balanced between the treatment groups and not expected to affect immunogenicity results. Across the studies, the average age varied. It was 40 in HBV10 and 54 in HBV16. In HBV23, a higher proportion of subjects were Black or were obese than in the other studies. In HBV10, the primary endpoint was met. The SPR in the HEPLISAV group was non-inferior to that in the Engerix group, and it was also statistically significantly higher. The SPR in the HEPLISAV group at week 12 was 95%. In the Engerix group at week 28 was 81.2%. The difference between SPRs was 13.7%, with a lower bound of the 95% confidence interval of 10.4%. In a post-hoc analysis, the peak SPR in the trial occurred at week 24 in the HEPLISAV group, and it was significantly higher than the peak SPR in the Engerix group that occurred at week 28. Now, it's also important to note that HEPLISAV achieved the same SPR much earlier, that is at week 8, that Engerix achieved at week 28. Similar to HBV10, HBV16 met its primary endpoint, demonstrating that seroprotection with HEPLISAV is again non-inferior to that of Engerix. In HBV16, the SPR in the HEPLISAV group at week 12 was 90.1%. In the Engerix group at week 32 was 70.5%. The difference in SPRs was 19.6%, with the lower bound of the 95% confidence interval of 14.7%. Additionally, HEPLISAV achieved its key secondary endpoint of a statistically significantly higher SPR. Now, similarly to HBV10, in a post-hoc analysis, the peak SPR induced by HEPLISAV was significantly higher than the peak SPR induced by Engerix that occurred at week 28. Again, HEPLISAV achieved the same SPR earlier at week 8 that Engerix achieved at week 28. Now, HBV23 also met its primary endpoint, demonstrating that seroprotection with HEPLISAV is non-inferior and the secondary endpoint of statistically significantly higher than Engerix in adults with type 2 diabetes mellitus. Now, in this population, the SPR in the HEPLISAV group at week 28 was 90%, and in the Engerix group at week 28 was 65.1%. The difference in SPRs was 24.9%, with the lower bound of the 95% confidence interval of 19.3%. Now let's turn to the secondary endpoints. Seroprotection for HEPLISAV was higher than for Engerix in the total population and across a variety of pre-specified subpopulations. This includes in all age groups, from 100% versus 94% in the youngest group to 91.6% versus 72.6% in the oldest group. Overall, the SPR in each of the pre-specified subpopulations was consistently greater than 90% in the HEPLISAV group and was much more variable in the Engerix group. Differences in seroprotection for HEPLISAV were also statistically significant in all these pre-specified subgroups compared with Engerix. The forest plot shows point estimates and 95% confidence intervals of the differences in SPRs that I showed on the previous slide. The vertical line at minus 10% is indicative of non-inferiority, and the vertical line at 0 is indicative of statistical significance. Now, the largest differences between the HEPLISAV and Engerix groups are in the populations that have been previously reported to have reduced seroprotection from alum adjuvanted vaccines. However, seroprotection rates are significantly higher in the HEPLISAV recipients in all the pre-specified subgroups. Now, in summary, HEPLISAV-B met its primary and secondary endpoints in each of the pivotal trials, with higher SPRs early, at peak, and in all adult subpopulations. Now let's look at safety. I'll present our safety data using 3 populations. And it's important to remember, particularly when you look at numerator data, that none of the trials were randomized 1-to-1. The safety population for HBV 10 and 16 are used to show solicited reactogenicity results and unsolicited adverse events. The safety population for HBV 23 will be used to show unsolicited medically attended events, that is, events for which people sought medical care. And then the primary safety population pools all 3 of the studies. So this includes all adults 18 to 70 in those trials, and the subject allocation ratio in this primary safety population is 2.4-to-1. We use it to evaluate death, SAEs, and immune-mediated adverse events. Now, first I'll describe reactogenicity and adverse events. Around 55% of subjects in both vaccine groups had a solicited post-injection reaction or an unsolicited adverse event. In HBV23, the proportion of subjects who experienced a medically attended adverse event was also balanced between the groups. HEPLISAV was generally well tolerated. There were no cases of vaccine-associated anaphylaxis, and there were no other serious post-injection reactions. Most solicited post-injection reactions were mild or moderate. They were self-limited and generally resolved within 7 days after injection. Now, in this analysis following all active injections, the frequency of local post-injection reactions overall was balanced between the treatment groups. The most frequent local reaction in both groups was injection site pain. Now, in the HEPLISAV group, 32% of subjects had a systemic post-injection reaction, 37% of subjects in the Engerix group. The most frequent systemic reactions in both groups were fatigue and headache, followed by malaise. Now, with both vaccines, there was decreasing reactogenicity with subsequent doses. Overall, in the primary safety population, deaths occurred in 0.28% in the HEPLISAV group and 0.21% of the Engerix group. The only imbalance in causes of death was due to illicit or therapeutic drug overdose with a higher frequency in the HEPLISAV group. SAEs, 4.8% in both groups. Immune-mediated events, 0.2% of the HEPLISAV group and 0.13% of the Engerix group. In the primary safety population, the percentage of subjects reporting any SAE was similar in both groups. SAEs were generally similar in nature between the two vaccine groups. However, I want to highlight two notable numerical imbalances. A higher proportion of HEPLISAV recipients than Engerix recipients experienced an SAE of acute myocardial infarction, and a higher proportion of Engerix subjects experienced an SAE of prostate cancer. The magnitude of the differences between treatment groups for these two events was similar, but in opposite directions. Now, these are typical examples of observing unexpected post hoc findings in a large safety database where over 1,400 different adverse events were reported. Now, let's look more closely now at the numerical imbalance in MIs in the individual trials. In HBV23, we identified a numerical imbalance in safety events coded to the single MedDRA preferred term of acute myocardial infarction. However, in HBV16, we did not see this kind of difference between groups. Now, in fact, the numbers are small. There's a lower proportion of subjects in the HEPLISAV group than in the Engerix group who had an acute myocardial infarction. In HBV10, there were no MIs, and this was a younger population. We were surprised, as you might expect, by this numerical imbalance in myocardial infarctions. And we were because there's nothing in the medical literature, there's nothing in our preclinical data, and nothing in our previous clinical studies that suggested MI should be a concern. But because of the medical importance of the term, we thoroughly investigated this observation. Now, to explore the MI imbalance observed in HBV23, we conducted a typical analysis for cardiovascular outcomes. First, we had identified and performed post-hoc blinded adjudication of all potential atherosclerotic cardiovascular events that are included in the gold standard atherosclerotic cardiovascular event composite outcome that's used in nearly all such trials, and it's referred to as major adverse cardiovascular events, or MACE. This entails analysis of a composite 3-point MACE in each of the three components. This comprises time to first event of death due to cardiovascular cause, non-fatal MI, and non-fatal stroke. We then evaluated in whom did these events occur, at what rate did they occur, and when did they occur? So this slide presents the cardiovascular events confirmed by adjudication. 0.33% of HEPLISAV subjects and 0.21% of Engerix subjects had adjudication confirmed MACE outcomes. The incidence of cardiovascular death and non-fatal stroke were similar between the two vaccine groups. The difference between groups was only seen in myocardial infarction. If the difference in myocardial infarction in HBV23 was caused by HEPLISAV, then you'd expect to see differences across the spectrum of atherosclerotic disease outcomes. In this case, cardiovascular death and stroke, but that's not the case here. Analyses of the composite and the component outcomes all had 95% confidence intervals that included 1. So we then looked at who had these events. This table summarizes baseline risk factors for cardiovascular disease for those who had MACE outcomes, and then in the total cohort, comparing the two vaccine groups at baseline. Overall, cardiovascular risk factors were balanced at baseline between these two vaccine groups. MACE outcomes were reported in subjects who were on average 10 years older than the overall cohort, and with about twice the prevalence of hypertension, diabetes, and hyperlipidemia. Now, in fact, most subjects who had a MACE event had 2 or more cardiovascular risk factors. Now, in addition, cardiac cath data showed that in the majority of MIs, these patients had multivessel obstructive coronary artery disease. So the MACE outcomes, including the MIs, occurred in people in whom you'd expect them to occur. So we then estimated the expected incidence of cardiovascular events based on age, race, and sex, comparing observed versus expected rates. In each comparison, the observed incidence per 1,000 person-years of follow-up in the HEPLISAV group was similar to or lower than expected. The expected rate of myocardial infarction in the studies was 2.6 per 1,000 person-years. In the HEPLISAV group, it was 2.4. But in the Engerix group, it was 0.7, or nearly 4-fold lower than would have been expected. In HBV23, it was nearly 7-fold lower than expected. Thus, MACE and MI events in the HEPLISAV group occurred at rates similar to or below expected. Now, this epi curve shows the timing of the occurrence of MACE events. Now, this is presented as incidence per 1,000 subjects to account for the 2.4 to 1 imbalanced subject allocation ratio. The triangles along the horizontal axis reflect timing of vaccine administration. MACE outcomes, as you can see, occurred over the entire duration of the studies. There was no clear evidence of clustering of events, and importantly, events were similar between the groups shortly after each vaccination. The imbalance in these events only begins to emerge at study day 100, with events occurring well beyond day 300 in both groups. In conclusion, we conducted a thorough investigation of cardiovascular events observed in the HEPLISAV program. We were unable to identify a biologically plausible explanation for this imbalance. The imbalance was observed only in one trial. MIs occurred in subjects in whom such events would be expected at rates that would be expected. There was no temporal association of events with vaccine administration. So we believe that the imbalance in MIs in HBV23 was most likely due to random variation in the context of very small numbers of subjects having these reported events while analyzing 1,400 different adverse event terms. Now, nonetheless, we will be conducting a post-marketing study to more definitively exclude any cardiovascular risk with HEPLISAV. So let's move on to immune-mediated events now. In the primary safety population, the most frequent new-onset immune-mediated event was Bell's palsy, 0.06% in the HEPLISAV group, 0.05% in the Engerix group. The only other event that occurred in more than one HEPLISAV subject was hypothyroidism, One of those events occurred in a subject who had thyroid papillary carcinoma. Now, a variety of other immune-mediated events occurred in each of the groups. They occurred in one subject each, and they were quite different, both in time of onset as well as their principal mechanism of pathogenesis. In the primary safety population, again with a subject ratio of 2.4 to 1, rare serious immune-mediated AEs were balanced, with 3 in the HEPLISAV group and 1 in the Engerix group. In the HEPLISAV group, there was an event of granulomatosis with polyangiitis. The event of Guillain-Barré syndrome occurred more than 3.5 months after the last active HEPLISAV dose and 5 days after an influenza vaccination. The event of cavernous sinus syndrome was thought to be the inflammatory condition of Tolosa-Hunt syndrome, but it was not confirmed radiologically, and it occurred 8.5 months after the last HEPLISAV injection. Now, in the Engerix group, there was one rare serious immune-mediated AE. This was microscopic polyangiitis, an ANCA-positive vasculitis that was also reported. Now, finally, as our immune-mediated disease assessment, we saw similar autoantibody development in HEPLISAV recipients compared to Engerix recipients. Anti-neutrophil cytoplasmic antibody, or ANCA testing, was performed retrospectively because of the event of granulomatosis with polyangiitis. More than 2,500 subjects were evaluated. There were no confirmed positive results other than the previously mentioned ANCA-positive vasculitis cases that occurred in each arm. Anti-nuclear antibody, or ANA testing, was performed in several trials prospectively. 5.5% of HEPLISAV, 5.1% of Engerix recipient developed these antibodies during a trial. Anti-double-stranded DNA was also performed as a protocol-specified assessment similar to ANA. 1.2% of HEPLISAV and 1% of Engerix recipients developed such antibodies. In HPV-23, we also evaluated development of antiphospholipid antibodies in 309 subjects. There was no difference in most of these antibodies, including anticardiolipin, lupus anticoagulant. There was one increase that we found. There was an isolated elevation in anti-beta-2 glycoprotein 1 IgM levels at week 8, 7.7% in the HEPLISAV group, 1% in the Engerix group. Now, such isolated elevation of anti-beta-2 glycoprotein 1 IgM has not been associated with thrombotic events in the medical literature, nor in our study. Now, the safety data in more than 13,000 adults show that HEPLISAV is well tolerated with an overall similar safety profile to an existing hepatitis B vaccine. Rates of post-injection reactions, adverse events, medically attended adverse events were largely balanced between the HEPLISAV and Engerix groups. The overall serious adverse event rate was similar for the two arms, with imbalances in individual terms that went in both directions, including acute MI for HEPLISAV and prostate cancer for Engerix. Comprehensive analyses of all new-onset immune-mediated event rates were also balanced, with no increase in any specific condition, and autoantibodies were also similar between the groups. Our post-marketing surveillance studies will be conducted by the Kaiser healthcare systems in both the Northern and Southern California regions. In these retrospective electronic medical record analyses, we'll specifically be looking at acute myocardial infarction and new-onset immune-mediated events. For acute MI, we'll be evaluating 25,000 patients who receive HEPLISAV and compare them to 25,000 patients who will receive another hepatitis B vaccine in the Kaiser Southern California region. In this acute MI study, a non-randomized cluster design will be used where some facilities will use HEPLISAV exclusively and others will use Engerix exclusively. Now, for immune-mediated events, we'll evaluate the same 25,000 patients that we'll evaluate in the MI study, and an additional 5,000 patients from the Northern California region. We'll compare them with a similar number of patients who receive another hepatitis B vaccine. Now, in conclusion, HEPLISAV induces high rates of seroprotection in all adults, including populations with reduced response to current vaccines. Compared with Engerix, HEPLISAV provides earlier seroprotection with a similar safety profile. HEPLISAV should increase adherence with a 2-dose schedule over 1 month. We believe HEPLISAV can play an important role in helping to meet the National Academy of Sciences goal of eliminating hepatitis B as a public health problem by 2030. Thank you.
Thank you. I think we'll go on to Dr. Nelson's presentation of the work group considerations and then do discussion after that.
Thank you, Dr. Jansen. Hello, I'm Noelle Nelson, the CDC lead for the Hepatitis Vaccines Work Group. Okay. Today, I will present a brief overview of the epidemiology and burden of hepatitis B in adults, adult hepatitis B vaccination coverage, cost-effectiveness of HEPLISAV-B, and the policy options and work group considerations, including the HEPLISAV-B immunogenicity and safety that was just presented by Dr. Jansen. This slide shows the adults recommended to receive hepatitis B vaccination, which includes household contacts of hepatitis B surface antigen positive persons, persons with sexual risk factors, and others, including injection drug users, residents and staff of facilities for developmentally disabled persons, healthcare and public safety personnel, hemodialysis patients and persons with end-stage renal disease, international travelers to regions with higher intermediate HBV endemicity at greater than or equal to 2%, persons with chronic liver disease, including hepatitis C virus, persons with HIV infection, and adults with diabetes mellitus. This slide shows the reported number of acute hepatitis B cases in the United States from 2000 to 2015. As you can see from the curve of acute hepatitis B cases, vaccination in the U.S. has been very successful with existing vaccines. Vaccine was first introduced for high-risk groups in 1982, and then in 1984 for infants born to hepatitis B surface antigen positive mothers. The estimated number of new hepatitis B infections in 2015 was 21,900, a sharp decrease from the almost 300,000 in the 1980s. This slide shows the reported acute hepatitis B cases by age group. From 2000 through 2015, the incidence of hepatitis B cases reported in the United States was consistently higher among the 30 to 39 year age group and lowest among the 0 to 19 year age group. From 2014 through 2015, the incidence of hepatitis B cases reported in the United States increased for persons in each of the age group, except among those in the 0 to 19 year age group. In 2015, rates were highest for persons aged 30 to 39 years at 2.6 cases per 100,000 population, and the lowest among children and adolescents aged less than 19 years at 0 cases per 100,000 population. Hepatitis V vaccine coverage for greater than or equal to 3 doses among adults aged greater than or equal to 19 years is shown here based on the National Health Interview Survey in the United States in 2015. Overall coverage was 24.6%. The high-risk group with the highest coverage were healthcare personnel at 64.7%, And as you can see on the slide, coverage for travelers, persons with chronic liver conditions, and persons with diabetes was low, with the highest being among travelers at 32%. To improve hepatitis B vaccination of high-risk adults, CDC funded 14 local and state health departments to implement hepatitis B vaccination programs. Awardees provided CDC with standardized reports regarding vaccination activities, high-risk settings, partners, doses administered, 3-dose series completion, and program challenges and successes. The study was from 2012 to 2015, where 161,171 hepatitis B vaccine doses were distributed, and 139,110 doses, or 86.3%, were administered at 459 settings, including correctional facilities. There were many challenges, including incorporating vaccination services and tracking vaccine doses administered in settings without dedicated vaccination staff. Six of the 14 awardees of this hepatitis B pilot project study were able to track dose series. The data from those awardees is shown here. Of persons who completed the first dose, those who completed the second dose ranged from 18.5% to 67.6%, or an average of 40.4%. Of persons who completed the first dose, those who completed the third dose ranged from 6.2% to 46.1%, or an average of 22.3%. So you can see that vaccine completion is low, even when vaccine is distributed to high-risk settings. Another study looking at the compliance with multi-dose vaccine schedules among older children, adolescents, and adults using data from the Vaccine Safety Datalink is shown here. 41.4 to 62.2% of persons completed 3-dose series within 1 year of the first dose. Slight increases are seen when data are looked at more than 1 to 2 years after the first dose. Among persons who did not complete the 3-dose series, 15.1 to 25.7% received 1 dose, and 12.5 to 21.2% received 2 doses. Again, showing the challenges in series completion. Next, switching gears, it will show the cost-effectiveness results of a study from 2013. This study was funded by Dynavax with Dynavax co-authors. The study shows that HEPLISAV-B has a favorable cost-effectiveness profile with incremental cost-effectiveness ratios less than $25,000 across all populations studied. The 3 populations on this slide include patients with diabetes, healthcare workers, and travelers. As you can see here, the ICER for patients with diabetes was $12,613, for healthcare workers $11,062, and for travelers $5,564. The cost of vaccine regimen completion rates and seroprotection rates were the sensitive variables in the models used. The limitations of existing hepatitis B vaccines include that they require 3 doses administered over 6 months, and there's reduced seroprotection in some populations. For example, in diabetics, there's a greater than equal to 90% protection for persons aged less than equal to 40 years, but a less than 40% protection for those aged greater than equal to 70 years. In renal disease, 77% of hemodialysis patients protected. And there's also reduced seroprotection among immunosuppressed, obese, elderly, and smokers based on various studies. The work group considered the following during work group deliberations regarding HEPLISAV-B. Compelling evidence of HEPLISAV-B immunogenicity based on the data presented by Dr. Jansen. Administration benefits, 2 doses over 1 month compared to the current 3 doses over 6 months. Favorable cost effectiveness based on the 2013 study by Dynavax. And a need for post-marketing cardiovascular surveillance to address major adverse cardiac event findings, as just presented by Dr. Jansen. Based on work group considerations, the pros that were discussed were increased immunogenicity, particularly in high-risk populations, administration, the 2-dose series over 1 month, and coverage, potential for increased series completion with the 2-dose series over 1 month. The cons, as previously described, in one study, acute myocardial infarction was reported in a higher proportion of HEPLISAV-B than Engerix-B recipients. The proposed policy option language, if HEPLISAV-B is licensed, is HEPLISAV-B vaccine may be used for adults greater than or equal to 18 years of age on a 2-dose schedule over 1 month. And the work group summary is as follows. HEPLISAV-B results in high levels of seroprotection, including among populations with reduced immunogenicity to hepatitis B vaccination. The HEPLISAV-B vaccine series, consisting of 2 doses administered over 1 month, will likely improve coverage for series completion. Most safety outcomes were balanced between HEPLISAV-B and comparator. However, in the HBV23 study, acute myocardial infarction was reported in a higher proportion of HEPLISAV-B than Engerix recipients, and safety will be monitored in post-marketing studies. So, ask Dr. Jansen to come back.
Thank you for both those very good presentations. Questions, discussion for Dr. Nelson and Dr. Jansen. Dr. Riley.
Dr. Jensen, I had 2 quick questions. On slide 16, where you report the outcomes, everything is reported except race, ethnicity, which you brought up in the demographics, so clearly you have the data. I don't know if the numbers are so small that that's maybe why it wasn't presented. So I was wondering if you could just comment on that, especially with Black patients having more diabetes, obesity, all the other areas where we would be concerned. And then my second question is probably an easier one to answer. Is there any data on pregnancy or inadvertent pregnancies?
So race, this slide shows the race data.
Oh, okay.
We didn't present it because race wasn't pre-specified. And the reason it wasn't pre-specified is race has not been associated with reduced responsiveness to hepatitis B vaccine. So we never looked at it as an endpoint, for example. But what you can see is in whites and blacks, Hispanic or Latinos, again, you see similar to results what we saw before. In Asians, there were much smaller numbers here. And when you see smaller numbers, HEPLISAV was non-inferior. It wasn't statistically significantly higher. I'm sorry, and your second question was?
Second question was whether or not there was any pregnancy data or inadvertent pregnancy
Very
data.
little. People were not supposed to be pregnant. They were, clinical trials. They were not supposed to get pregnant. Yes, they did.
There's only 4 million in the U.S. They're not going to get pregnant.
What we saw was we had 40 pregnancies in the HEPLISAV group and 20 in the Engerix group. The outcomes were very similar, but that's all.
Dr. Atmar.
You showed us that the seroprotection rates continue to go up in the HEPLISAV group beyond week 12, and in fact, some of the published literature, the peak was at week 24, and some of the geometric mean concentration data that's been published, shows a steady increase to that point. How How do you explain that? I mean, it's great that it happens, but why does that happen?
It's a challenging, we don't know, honestly. We haven't tried to explain it. What you do see is most of the increase occurs within 4 to 8 weeks, as you'd expect. That's what you see with most vaccines. What we're having a hard time explaining is why that continues to increase. Plasmablast, maybe, we just don't have a good explanation.
I guess it gets at the issue of the timing for safety events. If there's things going on related to that vaccination where there's ongoing immune responses, it makes it tougher to judge the later events that you occur. The balance is reassuring, but.
Well, we did do a systems biology study, and in the systems biology study, the immune clusters that you look at were increased clearly through 28 days after the second dose, so through 56 days, and they actually had all returned to baseline by 28 days after that. So the only long-term that you see is really the antibody development and to hepatitis B surface antigen. So we don't have any evidence that there's any ongoing immune activation.
Dr. Plotkin?
Yeah, I just want to, well, first of all, let me say, I think this is the first time I'm saying this. I do have a conflict of interest, and that is because I am on the board of Dynavax. Why did I join the board? And the answer is very simple, because this is an adjuvanted vaccine with a TLR agonist, in this case, a TLR9. And this comment then goes a bit more broadly, because I actually just came from a meeting on the immunology of vaccines in the future. And the point I want to make is that adjuvants are the future, that we are facing the development of vaccines that are difficult because of the biology of the disease, and we are going to have to use more adjuvants in order to develop effective vaccines. So we have, as you know, a TLR4 agonist licensed for HPV. The AS01B is, in a way, a more complicated TLR4 and lipid adjuvant, and this vaccine, as I said, is a TLR9 adjuvant. And as you can tell from the numbers, there's 1, 2, 3, up to 10. And in the future, the ACIP is going to have to deal with more adjuvanted vaccines, because they are clearly going to be needed for high effectiveness, as in the case of hepatitis. I also just want to mention one other thing, and that is this vaccine, for obvious reasons, is designated for adults who respond poorly. But there may be an application actually beyond the U.S., and that is in infants born to mothers who are hepatitis B positive, because there are failures, unfortunately, in that group. And this vaccine might actually be a good vaccine to solve that problem.
Thank you. Dr. Duchin?
Thank you. 2 questions. One, in the unexpected acute MI patients, it wasn't clear to me what the age range was of people who had that complication, and it looked like it went down as low as the 30s. Is that correct?
There was one 39-year-old who actually had a previous, it was, that was a stroke. It was not an MI, and that was a patient who had actually had a stroke in the same region from a vascular malformation.
I see. So there wasn't an unusual distribution of young patients in that?
No, it was
okay.
all the people who had MIs had at least one risk factor. Okay. Many of them had 3 or more.
Okay. And my second question is, has this vaccine been studied in people who failed to respond to Engerix-B in 1 or 2 series previously?
Not in numbers that I'm willing to talk about. It's 19. No. Yeah. was fine. The numbers are so small that I don't even, no, we haven't studied it.
Dr. Belongia.
Thank you. Given that thrombosis plays a role in myocardial infarction, is there any biological reason to expect the TLR9 adjuvant to have any effect on platelets? And related to that, did you look at other types of evidence of coagulation or clotting disorder, platelet aggregation disorder like deep venous thrombosis or pulmonary embolism, and was there any imbalance there?
Yeah, so first to answer your last question, no. There was in previous studies. So the reason we did the antiphospholipid study in HBV23 is that in HBV10 and 16, there were 5 PEs in the HEPLISAV group, none in the Engerix group, but remember, those were randomized 4-to-1 and 3-to-1. Because of that, we ended up looking at antiphospholipid antibodies, thinking, well, if there's a likely explanation, it would potentially be autoimmune. I say that because in tox studies, at 60-fold the dose that's used in humans, actually a 1018 causes bleeding. It does not cause thrombosis. It would cause the opposite. So we did look at thrombosis very carefully because of the MIs, specifically because of that concern, and we didn't see anything to suggest that that's true.
Dr. Schaffner?
Thank you. Bill Schaffner, National Foundation for Infectious Diseases. I have a couple of questions regarding the deliberations of the hepatitis vaccine work group, so Drs. Reingold and Nelson. But first, just a word of preamble. As many of you know, for many years, I've been trying to persuade you all to be more assertive in expanding the recommendations for the use of hepatitis B vaccine in order to achieve the goal of the interruption of the transmission of this virus in our populations. So apropos of the anticipated licensure of this vaccine, looking back at some of the recommendations, you recall regarding people with diabetes, they're recommended routinely to receive this vaccine up to age 60, but beyond 60, it's at the discretion of the physician. And that was really driven because the vaccines then available were less effective in that older population. This vaccine looks to be quite effective in that population. So my first question to you, and then I'll give you the second one very quickly, is has the work group started to look at that recommendation and maybe opening it up and making a stronger recommendation for the immunization of people with diabetes older than age 60 with this vaccine? In that context also, given the nice data that Dr. Nelson has shown regarding the occurrence of hepatitis B in our population and the recent increases, albeit small, but they're increases in populations, have you thought about increasing the universal recommendation to some other age, maybe up to age 40 or age 50? We really would like to interrupt the transmission of hepatitis B virus in our population. Thank you.
Thank you for the questions, Dr. Schaffner. So the work group has had preliminary discussions on the topic of universal hepatitis B vaccination based on discussions that came out of this ACIP meeting when the hepatitis B statement was presented a year ago. However, those have not progressed to the point of discussing diabetes any further in terms of more aggressive vaccine recommendation.
Other questions? Dr. Hunter?
I think I might know the answer to this, but I need some clarification or maybe just confirmation. I'm looking at slides 7 and 8, Dr. Nelson, of your presentation about especially 8, where the average completion of first and second doses. And as it applies to a more general recommendation of a vaccine for adults. My understanding from the little bit from slide 7 is that these were not, say, free-ranging adults that were waiting to be victimized by us clinicians to be recommended for any particular vaccine, but instead they were more parts of other programs and already selected out in high-risk situations and had some case management, perhaps by public health nurses. Am I misunderstanding that or no?
So this study included local and state health, patients from local and state health departments that already had, they were just high-risk settings. So, sorry, can you repeat? You want to know if they were already in any case management program for?
Well, what I'm getting at is that if we were to look, as a committee, to be looking at recommendations that were going to be implemented by clinicians taking care of, say, diabetics, I don't know, whatever age, 30 to 70 or whatever, yeah, I don't think the completion rates that you're looking at here would necessarily apply to that group, because you were looking at people who were in drug treatment centers and in correctional facilities or in special pilot programs that were, they had follow-up by a public health nurse who would track them down, just as the public health nurses at the health department. I trust them to track down people. Okay. I just want to make sure that we're not going to, in the future, look back at this slide 7 and say that applies to a different population.
Okay, I'll defer to Dr. Weinbaum. Thank you.
Cindy Weinbaum, Immunization Services Division, CDC. You're exactly right. And in this project, vaccine was provided to a variety of venues that saw people who are at behavioral risk for hepatitis B. The programs did not have any kind of additional infrastructure with which to implement this project. So they did not have dedicated public health nurses or any additional resources to follow up with doses 2 and 3. So it's true that these rates of receipt of doses 2 and 3 do not represent, the general population receipt of dose 2 and 3. And they certainly wouldn't represent the follow-up that you would expect for somebody who was in some kind of routine medical care and had, a primary care physician that was following them on a regular basis, as you said, like a diabetic.
Dr. Romero.
This question is for Dr. Jansen. So Dr. Atmar's question spurred a thought. And so have you looked or have you thought about what would happen if you received your vaccine, a patient received your vaccine, followed or concomitantly with influenza vaccine or some other vaccine? Would you expect a boost in their immune response? And this curve that you've shown with increasing antibody titers over time, does that imply that perhaps some other vaccine given at some later date would also be boosted?
At a later date or in a different arm, no. In the same arm at the same time is a study that we're thinking about.
Dr. Lee?
Thanks. This is a general question and perhaps specific as well. I think it would be really great as we're starting to dive into using toll-like receptor agonists as adjuvants to have like a long-term view on the monitoring safety of vaccines that use these adjuvants. And I don't know if there's other medical products where we could learn from the safety of those. I understand in different populations the context is quite different, but it still might be helpful just for us as a committee to be able to understand where are the opportunities to learn and think about what are the systems that exist that can actually start to study this more broadly. The challenge because even though you're doing a very large trial to monitor both efficacy and safety, it still may not be large enough.
And to me, we feel that the size of the study we're doing now, and it's a 13-month follow-up, is probably what's feasible for us. To me, the next step is VSD.
This is an excellent suggestion and in line with what Dr. Plotkin said as well. So, Dr. Moore.
Thank you. Just a very quick follow-up to Dr. Hunter. As one of the states that participated in the earlier study, I can say that the patients that were involved in that study are among the most difficult to get immunized. Many of them were in local jails. So there were jail-based programs or STD services within public health where there's not routine follow-up expected. So in fact, these would be behaviorally the most at risk, but also perhaps behaviorally the most facing the most challenges for follow-up over a 6-month period of time. So I think they're not representative of the general population, but in fact it isn't an overrepresentation, as was said. We didn't have additional follow-up for them to track them down. So it was catch as catch can, and the numbers reflect that. The challenges of those vulnerable populations. But I think also speaking to Dr. Schaffner's comments as a member of the working group, I'm hoping that as we have different vaccines with different performance and different opportunities to look at how we can do better at preventing disease in this age group, that we will start to look at it's appropriate to re-examine what we are capable of as new products come on the market with different performance characteristics, and look at things like age-based recommendations.
Yes, Dr. Reingold.
So in response to that and to Dr. Schaffner's comments as a member of the National Academy Committee that issued the report on elimination of hepatitis B and C in the United States, we certainly urged that much greater efforts be made to vaccinate those high-risk populations. And to the extent that this new vaccine can be helpful with that, that would certainly help advance the goals of that IOM report.
Thank you. Dr. Sun?
Yeah, this is for Dr. Nelson. So you pointed out that the current rate of new-onset hepatitis B in the U.S. is in the young adult population is the highest, I think 30-39 age group. What do we know about those cases? How many of those cases are actually vaccine failures versus just were never vaccinated? Do we have that information?
I do not believe we have the information on vaccine failures. We do know that the universal vaccine will, hit the adults in the age 20s, but not necessarily up to age 30, 39, or 40, 49. So they're probably unvaccinated. And then, as we know, the increasing IV drug use cases may also explain part of that. But I don't know, Dr. Ward? Yeah.
No, just based on the literature, the breakthrough infections with hepatitis B among vaccinated populations that lead to clinical disease is extremely rare. You do get breakthrough and core antibody positivity, but you hardly ever see clinical disease coming from that. So this rise in acute hepatitis B is among unvaccinated persons.
Thank you. Okay, I think we're going to move on to hepatitis A, and Dr. Nelson is going to give us an update on some recent outbreaks.
Okay. So I'm going to speak today about ongoing hepatitis A outbreaks in the United States. 5 of the 6 largest U.S. hepatitis A viral outbreaks in the post-vaccine era have occurred in the last 5 years, including 4 since July 2016. CDC has provided technical assistance in 5 large hepatitis A viral outbreaks since last summer, sending epidemic intelligence officers and staff to the field for 3, most recently to San Diego in the spring. 2 were foodborne associated outbreaks with foods imported from hepatitis A virus endemic countries, and 3 were person-to-person transmission. The Division of Viral Hepatitis has also been assisting on outbreaks among men who have sex with men associated with the current outbreak occurring in Europe. Over 1,600 outbreak cases have been reported to CDC in the last 15 months, with the Division of Viral Hepatitis laboratory sequencing over 1,400 specimens. To put this in perspective, 459 outbreak cases were reported in the 10 years between 2005 through 2015. California is currently experiencing the largest person-to-person, meaning not common source or related to contaminated food, hepatitis A outbreak in the United States since the hepatitis A vaccine became available in 1996. The number of cases, hospitalizations, and deaths from the California Department of Public Health website is shown here. These data were updated on October 13, 2017. As you can see, the majority of the cases are in San Diego, with 507 cases, 351 hospitalizations, and 19 deaths. The population mostly affected have been homeless and are persons with, who are users of injection or non-injection drugs. The hepatitis A viral genotype in this outbreak is primarily 1B. In San Diego County, since early 2017, the Public Health Services Division and the County of San Diego Health and Human Services Agency has been investigating a local hepatitis A outbreak. On September 1st, San Diego County declared a local public health emergency. As of October 19th, 2017, 516 cases, 69.2% hospitalized, and 19 or 3.7% have died. This slide shows the epidemic curve based on data through 9/11/2017. Of note, of the 325 cases with test results available of the 421 shown here, 64 or 20% have chronic hepatitis C infection, and 17 or 5% have chronic hepatitis B infection. The epi curve is considered stable at this point. San Diego has reported fewer new cases per week over the past 2 weeks than reported previously, but it's too early to say that this indicates a downward trend in the overall outbreak. The combination of long incubation period, difficulty contacting much of the case population results in delays in reporting. And this slide shows a map of the hepatitis A outbreak cases by zip code. And I show this slide just to illustrate the large public health response that has gone into this outbreak. There have been almost 1,200 vaccination field events, over 20,000 field vaccinations, and a total of almost 84,000 vaccines administered in the area of this map. Cases linked to California outbreak have also been reported in Utah, Arizona, and Colorado. The outbreak is ongoing in Utah, and the data are presented here. There have been 45 outbreak-associated cases, age range 23 to 69 years. 27 or 60% have been hospitalized. There have been no deaths, and the primary risk factors have been homelessness and drug use. In addition, about 15% of the cases have hepatitis B co-infection, 33% hepatitis C co-infection, and some with both. In a completely separate outbreak, not linked to the California outbreak, is ongoing in Michigan. This is also a direct person-to-person spread transmission outbreak. And it is also predominantly genotype 1B. Greater risk of infection is thought to be associated with injection and non-injection drug use, homelessness, or transient housing, very similar to the outbreaks going on in California. Data as of October 18, 2017, show 431 cases, 348 of primary cases, 25 of those 431 cases are secondary. So 86% of the primary cases have been hospitalized, and 17 or 4.2% have died. And I will mention that the number of deaths in the Michigan and the San Diego outbreak are quite high for what we have seen in the past with outbreaks. The epidemic curve is shown here from August 1st 2016 to August 18th, 2017. And you can see the increase in reported cases from the summer of this year until now. This illustrates an ongoing outbreak of person-to-person spread. In addition, another separate outbreak, which was recently published in MMWR, is the New York City outbreak among MSM, where 51 cases have reported from January to August 2017. This outbreak was genotype 1A. 24 of 25 serum specimens matched strains circulating in Europe among European MSM, and cases are still being reported in New York. So the hepatitis A epidemiology has shifted over the years since vaccine introduction. Past outbreaks were associated with asymptomatic children. And there was often infected adults who cared for them and then transmitted infection to other adults. However, since vaccine introduction, more cases have occurred among adults who are more susceptible. So as you can see, large population of adults are not immune to hepatitis A virus. The prevalence of the antibody to hepatitis A virus based on an NHANES study from 2009 to 2010 shows overall protection of 26.5%. This is lower in the 30 to 49 age range, which is about 13.5%, and higher in the greater than or equal to 60 age range at about 37%. Of note, in children today, age 6 to 11, based on the same study, protection was at 47%. So therefore, susceptible adults without classic risk factors are exposed through contaminated food or other sources of infection, of other risk factors, they may get infected. So older individuals are more likely to experience severe disease and adverse outcomes as well. In addition, the vaccination uptake among at-risk adults is low. Two-dose coverage for ages 19 to 49 years, based on the NHIS survey, was 12.3% in 2015 and 18.2% for chronic liver disease persons in 2014. If you look at data for ages 19 and above without an upper limit, the overall coverage is about 9% and lower 8.6% for those with chronic liver disease. Another distinctive aspect about recent hepatitis A outbreaks is an apparent shift to a hepatitis A virus genotype previously rarely seen in the US. Historically, of the 7 hepatitis A genotypes, the most common genotype that circulates in North and South America is genotype 1A. The majority of outbreaks that have occurred in the last 5 years have been associated with genotype 1B. The current outbreak in San Diego is a genotype 1B, but consists of strains that are genetically different from outbreaks of genotype 1B currently seen in Michigan, or previous foodborne associated outbreaks such as frozen strawberries and the frozen pomegranate arrow outbreak of a few years ago. A 2 to 3% difference in sequence region indicates a significant difference in strain. And just to remind everyone of that the hepatitis A vaccine recommendations were introduced incrementally. Targeted vaccination in 1996 to children at 2 years in communities with high rates of disease. And then in 1999 to the states primarily in the western part of the country with high disease rates. Universal vaccination was recommended in 2006 for children aged 12 to 23 months. And then for programs to be continued for children ages 2 to 18 years, and vaccination was to be considered in outbreaks in areas with increasing disease rates. And then there's a recommendation that any person wishing to obtain immunity could also receive vaccine. This slide shows the outbreaks identified in the United States from 1994 to 2017 with arrows for the ACIP recommendations. During 1994 through 2004, prior to universal childhood hepatitis A recommendation, there were 256 hepatitis A outbreaks identified in the United States. The number of hepatitis A outbreaks reported are on the vertical axis, years on the horizontal, total number per year represented by the blue line. When the incremental ACIP recommendations were made is represented by the arrows, as I just said. So during this time, in the box, an average of 23 outbreaks per year were recorded, primarily consisting of large community-wide outbreaks associated with person-to-person transmission, shown in red. Over the following decade, 2005 through 2015, only 31 outbreaks were reported, mainly associated with the contaminated food, an infected food handler, and other food service outbreaks. Taking a closer look at the last 10 years, there's a significant change in the values of the y-axis, which represents the number of individuals infected as part of the outbreak. 2013 was considered a busy year with 4 hepatitis A virus outbreaks reported, the largest involving over 160 persons in the pomegranate, associated with pomegranate arrows from Turkey, and was also genotype 1b. We see this striking increase starting last year. And in addition, there may be more cases. There's some uncertainty in these numbers, and there's probably approximately 200 cases unaccounted for in the current, based on the current line. So you can see this dramatic shift and increase in cases. In light of the ongoing outbreaks of hepatitis A among adults in the U.S., the demand for adult hepatitis A vaccine has increased substantially over the past 6 months, and vaccine supply to meet this unexpected demand in the U.S. has become constrained. Both manufacturers, GSK and Merck, are exploring options to increase domestic supply to address increased demand for the vaccine. Both manufacturers are working collaboratively with CDC to monitor and manage public and private vaccine orders to make the best use of adult hepatitis A vaccine during this period of unexpected increased demand. To address constrained supplies, CDC staff are working directly with public health officials to provide guidance about how best to target vaccine distribution. Of note, these constraints do not apply to the pediatric hepatitis A vaccine supply in the U.S. In terms of current product availability, for Merck, the supply of available hepatitis A vaccine will be intermittent through 2017. Following an outage during part of October, orders are anticipated to ship beginning the week of October 30th. For GSK, pre-filled syringes are currently out of stock, but a limited number of vials are available to order with ordering controls in place. In addition, GSK is maintaining a limited medical reserve and continues to consult with public health officials to help support urgent public health needs. GSK anticipates limited resupply of pre-filled syringes in early mid-November 2017. Twinrix, GSK's combination hepatitis A, hepatitis B vaccine, is currently available for order. In light of these ongoing outbreaks and now constrained vaccine supply, I want to talk about the homeless population on the next few slides. Little is known about hepatitis A immunity among homeless populations in the U.S. Homelessness is not considered an independent risk factor for hepatitis A viral infection. Older age, duration of homelessness, and injection drug use may indicate hepatitis A viral immunity. The work group recently has considered the following question: should homeless be included as a hepatitis A risk group for vaccination, either for routine vaccination before outbreaks occur in so vaccinating settings where homeless are frequent, or just in outbreaks, outbreak vaccination. The following are the considerations that were discussed by the work group. There's a higher risk for high morbidity and death among homeless, often due to associated comorbidities. Often, homeless have additional risk factors, such as malnutrition, alcoholism, injection and non-injection drug use. Homeless often live in poor hygienic settings, causing increased transmission. And routine vaccination, example in shelters or ED, during ED department visits, over time may be feasible, whereas it's easier to implement in those settings than in outbreaks when vaccine supply is constrained. In addition, the work group talked about catch-up vaccination, and universal hepatitis A vaccination was also discussed. So I just want to, before the discussion, I just want to acknowledge the Division of Viral Hepatitis Incident Command Group, as well as support from the CDC Division of Emergency Operations, the Division of Viral Hepatitis Laboratory, the Immunization Service Division, and then our state and county partners, such as San Diego, California Department of Public Health, Utah Department of Public Health, Michigan, and also Colorado and Arizona, who we've been working with as well. Thank you.
Thank you, Dr. Nelson. Questions for Dr. Nelson? Yes, Dr. Stevens.
Can you comment further on the mortality associated with these outbreaks in terms of hepatic failure? What's going on in terms of mortality? I'm sure, is it age-related, or are there comorbidities?
We believe it's related to multitude of factors, including the age and the comorbidities, potentially poor nutrition, and other injection, non-injection drug use, and other factors. Okay. Go ahead, John, if you want.
I agree. I think that's exactly right. We think the acute on chronic hepatitis, probably alcohol also is in there, with as well as the just the nutritional status of these individuals, and probably when they're seeking medical care, when they're identified, I'll bring it together to result in this several-fold higher mortality rate than you typically expect for adults with hepatitis A.
Dr. Duchin?
Thank you. I wanted to comment on the issue of homeless persons and hepatitis A. I encourage you to make a recommendation that would add the persons who are homeless to the list of others who are indicated to receive this vaccine. We've been trying to do vaccination of our homeless population in Seattle, and as you know, across the country, the numbers of homeless persons are rising. They're living in conditions that are often very unhygienic, unsanitary, very limited opportunities for toilet use and for hand washing. It's a perfect setup for the spread of viral hepatitis. Because of the constraints of vaccine supply, and we're very limited what we can do, but we thought it would be a better idea to immunize our population before an outbreak occurred than after one occurred. But I do think that these people are subject to a large amount of health disparities and poor outcomes, and particularly vulnerable to hepatitis. So thank you for considering adding them to the list of indicated populations.
Thank you, Dr. Duchin. I will mention that we've only had preliminary discussions with the work group so far. In general, the work group was favorable to adding homeless as a risk group. However, we need ongoing discussion in order to make that continue those deliberations.
Yeah, thank you. And I do realize that the data are limited on the seroprevalence of hepatitis A among homeless populations, but the limited data that are available suggest very high levels of hepatitis A seroprevalence, upwards of 50%.
Thank you. Dr. Maldonado?
Yes, I just wanted to comment on the San Diego situation specifically. there was also, so as a precursor to the homeless issue, there was quite a large effort to move the homeless groups away from the center of town, the tourist areas. And so a lot of the people were forced to move into even worse conditions than they were living in while they were in the center, where there were, again, more access to facilities that also were high tourist trade areas. So I think that's another consideration, is when, I guess, if EIS officers are going back to really get a history maybe about why people are living where they are, because these were not only homeless but displaced homeless, so they were living in even worse conditions, and that's really when the outbreak really took off, at least this current one.
Thank you.
Thank you. Any other questions, discussion? Oh, I think you're
Before lunch.
hungry. I think it's time for lunch.